Good morning, everyone, and welcome to the February edition of Tennessee HFMA's Tennessee Trains on Tuesdays webinar series. My name is Merle Glasgow, and I'm a principal with Wheelhouse LLC, an executive management and private equity firm located in downtown Franklin, just a few minutes south of Nashville. I'm also a longtime member of Tennessee HFMA and will be moderator for today's webinar. On behalf of the chapter, I'd like to thank all of you for your attendance and interest in today's topic, value-based contract management. Some of you may have already downloaded a copy of the presentation slides from the chapter website. If you haven't done so, but would like to after the session, they'll be available via the link on the Tennessee HFMA website. There's also a link down in the chat box section in the Go-To Webinar Control panel on your screen. There is an updated version of those slides that the speaker is going to be providing, so you might want to wait until after the updated version has been posted. Before I introduce our speaker, I'd like to, I need to share with you a couple of announcements. First announcement is registration will soon be open for the next webinar in this series, which is scheduled to take place on March the 8th, where the focus will be on Medicare Advantage shadow billing. Visit the Tennessee HFMA website at tnhfma.org/webinars for more information on that event. Registration is currently open for the 2016 Dixie Institute, which will have the theme Harmony in Healthcare. This annual regional conference is designed to support HFMA's commitment to providing programs that enhance the growth and development of its members. It brings together HFMA members from 5 different states: Alabama, Florida, Georgia, South Carolina, and Tennessee. This year's conference will be held on March the 20th through the 23rd in Nashville. Please visit the website at hfmadixie.org/2016 for more information. That link's also posted on the Tennessee HFMA website. Last but not least, in regards to upcoming events, registration is also currently open for the Payers Summit to be held March 8th, 9th, and 10th in Gray, Knoxville, and Nashville, Tennessee. Each payer will discuss current issues and trends with their respective programs, as well as upcoming changes and initiatives. Topics to be covered include post-ICD-10 updates, bundled payments, appeals, updates for 2016, and you can visit, again, the Tennessee HFMA website under the Education tab on the home page. Just click on Payer Summit in the drop-down menu for additional information. And then one final housekeeping note before I introduce today's speaker. If you do want to obtain CPE certificates and credit for today's participation in the webinar, there are 2 things that you must do in order to obtain that certificate. The first is you must be connected to the webinar for at least 90% of the duration of the session. And the second requirement is that you must respond to at least 2/3 of the polling questions. The speaker will pause temporarily throughout the presentation in 3 different spots and ask a polling question that pertains to the information that has just been covered. So again, very quickly, must be on the webinar for at least 90% of the session and must respond to at least 2 of the 3 questions that will be posed during the presentation. So with that out of the way, it's my pleasure to introduce to you today's presenter. Nick Hilger is a partner with JBA eHealth Systems, a revenue cycle middleware solution provider to hospitals and physicians. Nick has spent the majority of his professional career as CEO of different health systems, including Allina and Health East Health Systems in Minnesota, the Health One Health System in Colorado, and with Columbia and HCA in Illinois. Following Nick's health system leadership experience, he's advised and launched startup health service ventures, including United Surgical Partners. He was principal with Dorsey & Whitney, a legal consulting firm, and advised major health systems in the area of hospital-physician partnerships and joint ventures. Immediately prior to joining JDA, Nick was a senior executive at United Health Group, working in strategic outreach to health systems. He has deep strategic and operational experience in multiple healthcare industry sectors, and Mr. Hilger has received his BA in finance from the College of St. Thomas in St. Paul, Minnesota, his master's in healthcare administration from the University of Minnesota, and he's also completed the program in management development at the Harvard Business School. So without further ado, I'd like to turn it over to Nick and let him get started with the presentation.
Thank you very much for the introduction. I must be very old because of having done all of those things. Anyway, thank you all for attending today. You can tell from my background, I come from a from an environment that really looks at the total revenue cycle environment, really from the hospital's perspective primarily. Did spend a little time in the managed care world, and then more recently I've really dedicated a lot of time into figuring out how to deal with some of the changes in the revenue cycle environment. So really what I want to do today is kind of focus on the value-based contracting, but more importantly throughout the whole revenue cycle, not just in the managed care side. And what I'm going to focus on today is really more of the perspective of a health system. I also do some work with payer organizations around the country as well, but we're going to specifically kind of go through that. So I'm going to start with some explanations, kind of look at the details of value-based contracting, and then do some specific planning for all of you that might be working in that environment. So first and foremost, why is this all happening? If you go to the first slide, I'll take it through this. Why value-based payment? Well, first and foremost, it's kind of a societal belief that's come up in the last 5 to 10 years is, are we getting good value for what we're paying for healthcare? And we also believe that we're spending way too much money and we're not really getting better outcomes. I think many of you may be aware of the concept of the triple aim, which is really talking about lower cost, better experience, and better outcomes. And really that's what's driving this. And secondly, the managed care organizations are clearly seeing an opportunity to enforce their evidence-based guidelines and promote lower cost alternatives for these high cost procedures and services. And finally, and I think you're seeing this with the new leadership at CMS, Medicare and Medicaid are really going pretty aggressively into the whole area of value-based payment. And again, I think that there are many people that I talk to around the country that believe that this is a one and done phenomenon and that we'll go back to the fee-based services, but I tend to disagree with that kind of thinking. So what is different about value-based payment for revenue cycle management? We talk about this a lot, but what are the unique differences? First one, and I think the one that a lot of people are struggling with right now, is negotiating and executing understandable contracts. I don't know how many of you work in the managed care environment, but many of the ACO arrangements and the value-based arrangements that are being done right now are really being done kind of in a generic way, but there isn't much in the way of contract adherence to that. So really the key thing there is what's included in those contracts and what's excluded in those contracts. I'm going to go into quite a bit of the specifics of value-based contracting in a moment, but this is a whole new world for people working in managed care because we've never had to negotiate and build these kind of contracts. A second major area that's different is that health systems really have never had to deal with identifying discrete covered lives before they arrive at the organization. Really, it's always been you get admitted, we get the information, we register them, etc. But in the world of value-based care, you're going to be identified as a health system having responsibility for maybe 10,000 lives with an Aetna plan, maybe 20,000 lives with a Medicare plan, shared savings, etc. And basically, your system is going to need to be able to identify those folks and where they come in. So if they are an Aetna patient and you're doing that work with Aetna, they may well be part of an Aetna ACO program. And unless you have the ability to identify those people up front and even before registration, that's going to cause difficulty. A next area that you've never had to do before is really attributing cost and revenue to multiple providers at the same time. Really, most of all of these systems are really anticipating some level of shared accountability that is going to be there relative to the ACO environment, really relative to a number of bundled agreements and episode agreements, etc. But again, it was always one doctor doing one procedure at one claim price and sending that in, and then the next one doing the next one, the next one. Now we're going to have to do attribution, and that's a skill set that typically doesn't exist in most health systems. The next one, which is very technical in nature and one that I think people are struggling with right now, is that claims management, which has been a fairly stable environment for the last 30 years, we're going to have new elements put into the claims environment, which is going to be taking that 837 and putting additional segments in there, and that's going to cause all sorts of difficulty with adjudication platforms and building claims in the legacy systems, etc. The next area is going to be a new thing for us because we're not going to know when to post contractual adjustments. As many of you know who may have dabbled in this so far, basically this is a retroactive reconciliation in most cases. And so the whole notion of contractual adjustments, which have been working pretty easily over the last several decades, is going to be an issue. The next area is a reconciliation of the payer payments, if you will, the remittance advices that come back when you're doing your normal work. We're going to have to figure out how to reconcile those based on their interpretation or the hospital's interpretation of what the value-based elements are, and I'll go into that quite a bit here in a moment. And then we're going to still have patient receivables in the new value-based environment, and that's going to create its own issue because you'll deal with things like preventive care and authorization needs, et cetera, et cetera. So that's going to get more complicated in value-based. And then finally, the finance divisions of the organizations are going to have some difficulty, I think, in really getting finite and granular net revenue reporting. So really the combination of all of those items, which I'm going to go into in some detail here, is really what I think is the difference. That's what the industry has not had to deal with in the past, and now it's going to have to deal with it. So just quickly, what are we doing now? Yeah, pretty much the same thing we've done for 30 years. You know, it's pretty much standard fee-for-service contracts, and for the most part, they're pretty interpretable. And, you know, the legacy patient accounting systems are, you know, some are newer, some are older, but basically what they do is they enter charges and produce claims, and you go through an editing process, and that's pretty standard stuff. And, you know, the same thing, you receive your payments and you look at denials management and things of that nature, and you show what the patient responsibility is, and your contractual adjustments are posted at time of billing or payment. And, you know, basically the system is pretty predictable. I don't think that you know, some systems do better than others, but by and large, that's really where we are now in RCM. And if you think about the slide prior to this and where we're going to be talking about the rest, the legacy accounting systems that are out there right now are going to be hard pressed to be able to drive that kind of intelligence and that kind of flexibility in the deal. The next slide, I just want to talk a bit about what the intermediate time is going to be, and what I call compounding the transition. Fee-based payment will continue for the foreseeable future, and in fact, fee-based payment will be the underpinning that will be driving value-based, because you have to start somewhere. And you know, don't for a minute think that I'm suggesting we're throwing out fee-based payment and CPT codes and I-10 codes and all of the EDI transaction sets that we currently live with. They will certainly be here, and they'll be here both for hospitals and physicians. They may become a little bit more merged, et cetera, as we go on, and we'll talk about that. But that's the deal. The second one, I think, is a big problem that's going to be hard on health systems, and actually on payers as well. I think that the payers, I think predominantly, because most of my work is in the delivery side of healthcare, that we are going to have to deal with patients of different stripes, so to speak. Whereas within a United Healthcare, we may have a PPO product, an HMO product, a value-based product, a senior product, and maybe a Medicare Part C product, that all coming from the same payer, and we're going to have them kind of mixed and matched between fee-based and value-based really over this next period of time, and again, it does put pressure on a system that is going to have enough difficulty with its current system, let alone trying to enroll all of this. And again, it's really the identification and being able to identify which patient, which enrollee is in which plan, with which payment systems, and what value propositions are part of that. And again, the next bullet says really value-based approaches will change, you know, a lot. I mean, at best, we're at the infancy in this business. And again, I talk to people around the country, and some of the executives in the health system side are just, sort of in denial. Nothing's going to change. This will just go away. And all we've seen so far are some shared savings, which is no big deal. And what's so difficult about that? That's just, that's not hard. But I think value-based approaches are going to change dramatically. I've been spending a lot of time with leadership at the health plans, and if you're watching the market, we've gone from a few pioneer programs with Medicare, which was really no big deal, to now several thousand variations of ACO plans that are beginning to crop up. Every day I read that Aetna has signed another 50 new ACOs, and Anthem is doing this, and United's doing that, and the government's doing that, etc. And as those things become more mainstream in the managed care environment, they'll start changing the rules, because right now they have, as the payer market, very little experience and very little technology that's able to build and track these kinds of new things. And then the legacy patient accounting systems will continue to produce your basic transactions, no problem there. But I think they're going to be hard-pressed not having the analytics to be able to identify the differences between the different patients that are on different kinds of programs. And so what I call compounding the transition is something that is going to be an issue. So here are the requirements, and we're going to spend the rest of this time really digging into all of this, because I'd like to spend some time acquainting you with what I think and I'm seeing as changes in the value-based requirements. So we're going to talk about these transparent agreements. I'll get to that in a moment. Shared accountability is another big deal, because depending on whether you're in California, where you have very integrated physician groups, whether you're in the world of the Geisingers and the Mayo Clinics, where you have everybody in a single environment, that's great. But the real world has mostly individual physicians that might be employed by the hospital, and maybe independent organizations, etc. And the shared accountability is going to be tough. I'm going to talk about that. Timely and relevant data interoperability, sort of a mouthful there, but the reality is, and I think we all agree, that the timeliness is going to be the value proposition in doing value-based requirements, because finding out 6 months later how you're doing is not going to be of any value to management trying to build a reasonably profitable environment with these issues. And then the whole notion of interoperability between physician group practices and the hospital and the payer, really, and I think we have to take a whole new look at this connected technology between all the different relevant parties and the stakeholders. The next one, adherence to evidence-based medicine protocols. Obviously, we've been looking at this for the last 15 years, and certainly evidence-based medicine is here to stay. It drives much of what we do, but now it's going to be tied to payment. And again, I think that's something that the systems aren't quite ready to deal with yet, and we're going to have to put those protocols together and get consensus building on that. The next one is engagement between clinical and RCM. The revenue cycle people, and let me stop for a second. Value-based payment has very little to do with the clinical practice of medicine. It has everything to do with revenue cycle technology and being able to interpret payment around a much fuzzier environment. So revenue cycle, in my opinion, has been left out of this conversation far too long, and it needs to get into it. So there'll be a lot of engagement between the two. I said a moment ago, connecting technology. This whole issue of timely enrollee patient engagement is important, and financial and clinical reporting. And now I'm going to go through each one of these and try to make some points in here that state, what I think you're going to all need to be able to deal with. So transparent agreements, let me be very clear at the beginning. There's sort of an infinite number of agreements that can be attributed to value-based, but they kind of come into these different areas. The shared savings arrangements. And again, I don't know how good a work some health systems do or don't do, but getting the information, historically trying to get 2 to 3 years of claims information and understanding what population is where, it's, you have to figure out in that environment, at least 2 years of that. And again, you have to look at all of these things. You have to really identify your network. Who are the physicians contributing to that shared saving arrangement? And it could be simply a physician group, or it could be simply a hospital, But for purposes of this conversation today, I'm calling it a health system, which means hospitals and physicians together. And that's where I'm thinking that's where the future is going, and I think we have to be aware of that. The second area of agreements are bundled procedures and episodes, and I think we've kind of stumbled into that a little bit as an industry, but not doing tremendously good work in trying to figure this out. Here's an area where people really need to do their homework and look at that again, another 2-year to 3-year historical period. You need to do side-by-sides, taking what has been happening in your environment and juxtaposing them to the EBM guidelines, and then trying to figure out how could we make a living on this if we do these bundles. I mean, should we not get in this business? Should we get into that business? And I know that there's always the knee-jerk to saying, well, I better get this or my competitor will take it, but that's something people really need to look at. Episodes are a little trickier in the context you've got time as an issue, and so the bundled episodes, which have been really slow on the uptake, those would be things like congestive heart failure, maybe stage 2 breast cancer, where you have a longitudinal care environment, maybe even some of the high-end orthopedic procedures, which you'd look at an annual episode of back or hip. Procedures are pretty good because you can just you can take a number of hospital revenue codes and physician CPT codes and just say this is it, and we're going to look at these, etc. But episodes are a little trickier. Then the second environment, so you start with shared savings, pretty simple. You're just doing macro looks. The second one being some bundles where you're putting together. Now the third area, which we're going to principally talk about today, is the whole issue of performance-based agreements, which is about value-based care. And you can think of it in two different environments. One is process-based, the other is outcome-based, and we're going to go through these, and I want to walk through them fairly quickly, but kind of give you a sense of what it is. This is the first one is kind of like core measures for those of you who work in the business and you work in utilization management. These are core measures that the federal government says have to be done in order to get paid for certain things. And that's really what process-based on the clinical side means. And process-based on the administrative side is a lot of registration requirements and notifications to the payer. So if you play by the process and you do that according to the agreement, you will get additional payment. You'll get the same payment without withholds, etc. And so these are all, and again, I'm not going to go through a specific contract today. They're being developed as we speak, and I've seen a number of them, but I think that the key thing here is to think about these things as elements of value-based. How do I live within that as a member of HFMA? By the way, I'm a First Illinois HFMA. That is my deal, but I really like working with the HFMA groups. So that was the process-based. Now the outcome-based agreements, you're going to typically in three different areas. You have financial performance, kind of shared savings. It's more we're going to take a look at this population specifically, and we're going to look at that outcome in a number of different ways. And it may not be purely shared savings. It may be targets. It may be etc. And it may or may not be a corridor with a 2% win and a 2% loss. But again, it's going to be financial performance and an outcome-based agreement. That through again a United or a Blue Cross or whatever. Clinical outcomes gets really tricky, and this is where I think we're going to have to put a lot of energy into this. What I talked about earlier of the integration of clinical and RCM. And this is going to be something that, and again, these are in the agreements. These have to be in the agreements when you're discussing them. And so that will give you guidance as to what you need to do in your particular environment. They may be very crude and simple, or they could get very complicated. For those of you academic centers here, I think if there are some on the call, this would look a lot like your transplant agreements, where you would be looking at, you're almost combining a bundled episode with a clinical outcome, and that could be mortality, morbidity kind of issues. It could be all sorts of things. But here's an environment where your clinical leadership really needs to become a partner in this whole contract management world. And I think that's a very rare occasion if the head of managed care and the chief medical officer are spending time talking about negotiating an agreement with Aetna Healthcare. I kind of have to chuckle at that meeting. You've been an ex-CEO of the health system, and I'm trying to wrap my head around getting the CMO and the head of managed care together to do a contract, but that should be kind of fun to watch. The third area of outcome-based agreements is patient perception of care. This is a really big new issue in value-based payment, and more to follow. I'm going to go into that fairly deeply because this is a big deal now. I mean, we all do, all your health systems and your medical group practices say, hey, how did we do? But now it's going to be tied back to their payment. And the key thing there is how do we get it? How do we influence it? How do we get to that point? So that's the whole issue of outcome. The next area is hold on a second. So that's the end of my agreements piece, and I'll ask you a question about that in a minute. But that's kind of how we're going to go through the agreements, and please make note of that for those of you who are in the I'm sorry, I hit this wrong. We're gonna now move on to the rest of that list, but please, in that agreement part of it, I'd be more than happy to chat with any of the managed care folks that have an interest in taking a look at some of those points again. They're much more to it. I'm doing today in an hour what I do usually for a day, an entire day's workshop, what I do with health systems. So I just want to be going through this relatively quickly. The next area is shared accountability, and this is a big deal too. This is physicians and hospitals, always been separate. Even if they're employed, et cetera, you have your physician group and you have your hospital group. The value-based environment has to merge these silos, and you have to be on that. Interoperability, managing the process is going to be a big challenge, and that's going to be something that everybody's going to have to get their arms around. Now you're going to have to manage costs, revenues, and risk, and again, that shared accountability is I think the biggest cultural challenge in the healthcare industry. I mean, it's gotten a lot easier with employed physicians. I'm old enough that physicians were separate environments when I was running hospitals for the most part, and they were really separate. Now there's a fair amount of at least primary care employment and getting more and more subspecialty. But even in that environment, I think every community has independent physicians and employed physicians, and if you're really going to go after this kind of business, you're going to have to learn how to share accountability, and that's not easy. And then this whole managing outcome and patient perception, integrating enrollees and patient portals, et cetera. And when I mean shared accountability, it's not just the hospital integrating with that enrollee, it's the doctor group integrating, and how are you going to combine all of that? How are you going to take that patient perception and say, hey, I really had a great experience at the hospital, I didn't like my doctor, and how are we going to deal with this sort of thing, and how are we going to get all of that put together in the same environment? The next area on that list of things, I'm sorry, I've got a really jumpy mouse here. The timely data interoperability. Again, legacy IT and practice management systems are separate in different platforms. We need to, as an industry, figure out how to get those working on the same platform and trying to get there. There's a care and case management challenge. How are you going to be able to track care management across these systems that are these value-based systems? Charge capture and claims management. One of the real, I think, one of the real bedrocks of this is how are you going to get claims merged between the hospital and the physicians in order to take a look at population health management and bundled procedures and bundled payments, et cetera. How are we going to handle referral management? And again, all of these, I think, should be checklists for you guys to understand or to start thinking about how are we doing where we're in our environment to be able to make this happen better or not. And that's important. Patient identification and eligibility. I keep coming back to that because we have never had to do that, and this can't be done on spreadsheets. We're going to have to get, at some point, I talk a little bit later about the kind of platforms that you should be looking outside of the existing system to begin looking at how that can help you. Payment reconciliation and attribution. You sort of can't wait 6 months to start identifying that this service happened with this physician in this site with this health plan, And so if you don't have data interoperability amongst the group, and I'm talking about revenue cycle interoperability, how are you going to know how to do that? The next area is performance reporting of interoperability. The enterprise, and in all of these, I don't suggest that it's necessarily for an ACO or necessarily for a non-ACO, but in all kind of performance reporting, you have two options. You can rely on the third-party payer to tell you how you're performing, or you can do it yourself and compare that to what the payer is doing. I think in most circumstances today, health systems are waiting for the report from the payer to say, how are we doing? And, you know, if everybody's comfortable with that, then so be it. I think it does suggest that health systems should be a little bit more on top of their own performance without having to rely on external people to tell them how they're doing. The next area is evidence-based protocols, and that's what we talk about in that list. And then managing and reconciling services. The medical staff departments, in my opinion, of hospitals are going to take an expanded role of really trying to identify what it is that they're going to sanction, as it were, for certain capabilities. In medicine, it could be in the treatment of diabetics upon admission to the hospital, you know, for orthopedics, for cardiology. Take the different departments of the hospital. In a smaller hospital where you have medicine and surgery, I think that you're going to have those two departments fundamentally come to grips with what would be their approach. Primary care is going to be critical in all of this. That goes without saying. And that whole issue is really going to be around what you would call preventive care. There are certain elements in value-based care which are going to encourage certain early things of early staff development or early patient development for, you know, such issues as non-smoking and obesity, etc. And a lot of those services are going to really be driven by the primary care people. Preventive care services obviously going to be something that's going to have to be identified. Interaction with health plan directors. I think more and more the chief medical officer of the hospital is going to have to get in touch with the medical directors at the health plans, not just the managed care people. And then finally, performance measurement as an issue of how are you going to measure how your evidence-based medicine is going. This next area of I want to spend a little time on this is this enrollee patient engagement. Again, it's hard to tell, you know, whether or not you're a large corporate, sorry, the train comes by. The issue of receiving and storing and updating enrollee demographics and plan information, obviously a big issue. And then you have to get that information across the health system provider network. I'm wondering if we should maybe stop and ask a question. That train is really noisy. Sorry. Anyway, then identifying patients covered by value-based plans and determine eligibility. This again is something that's going to be hard for your patient access folks, and I kind of wind up the presentation talking about the sub-departments of revenue cycle, because, you know, I consider that about 5 or 6 different departments within revenue cycle. And then determining patient statement responsibilities. How will the health system be sending statements out to patients on this patient engagement? And more likely than not, it's going to require a next level of electronic communication with patients for this value-based, because remember, these patients are going to have their typical their typical deductibles, etc. But they're going to have all sorts of personal incentives in there that they're going to get additional reductions, etc. And you need to know that as a healthcare system as to what is happening with that patient along the way. Probably 20% of the patients, the old 80-20, 20% of the patients are 80% of the cost. And those would be the patients you'll have to identify, because they'll be the ones that are going to specifically make or break a value-based program, and how are you going to connect with them? And again, I think you can either wait for the health plan to do that, or the health system itself can have its own way of talking to those patients. So I'm going to stop here, and let's go ask question number 1. Let's do question number 1.
Yeah, great, Nick. Thanks. I appreciate it. Let me see if I can open the window that will display the first question. So what should be displaying on your screen now is a window that's titled Quick Poll. And the first question that Nick has is value-based contracting eliminates one of the following. So from your station, if you can go and select one of these following options. Option 1, hospital charges. 2, physician charges. 3, UB and HCFA claims. 4th option is all of the above. 5th option is none of the above. So if you want to take a few seconds and select one of those. I'll wait a couple more seconds to let everyone get their votes in. Okay. I'll go ahead and close the poll and share results. And what you should be seeing now are the responses. So it looks like 0% of you selected hospital charges, 7% physician charges, 9% UB and HICPA claims, 13% all of the above, and 72% none of the above. So Nick, I'll turn it back over to you, and you can address the correct answer and any comments you want to make to that. And then you can pick up the presentation right after you finish that.
Okay, yeah. Well, it was the 72% that were correct. There was none of the above. It's not going to get rid of anything. It's going to add to. So anyway, kind of a trick question, but anyway, let's go back to the patient engagement piece, which I'm going to ask a question about in a little bit. And again, I'm sorry I had a train coming through. For those of you who couldn't, if you wonder what that odd noise was. Anyway, just this patient engagement piece, I can't stress hard enough that's going to be something that hospitals have never been able to really get their arms around with knowing in advance who's there that they're responsible for. And I'm simply saying that the patient access folks are really going to have to step it up, and there's nothing wrong. They just haven't had the tools to be able to do that. And so more involvement with the health plans, more involvement with Medicare, more involvement with the different environments, and that's a big issue. And I think what I'm going to do is I'm going to ask question 2 right now. We'll get 2 of them out of the way at the same time.
Okay, let's see if I can pull up question number 2. And remember, everyone, that you, in order to obtain the CPE credit, you must answer 2 of these 3 polling questions. So let's see.
Well, yeah, we can do it now. I just wanted to get that because I'm going to run through now the last part of the presentation.
Okay. So the second question is, which clinical elements are part of VPP? And if you can select one of the following options: admitting diagnosis, discharge summaries, patient outcome questionnaires, progress notes, or none of the above. And I'll give you a few seconds to get your answers in. A couple more seconds. Okay. So the answers or responses should be displayed on the screen now, and it looks like the majority of you picked option 3, patient outcome questionnaires.
And that is correct. And that is correct. Thank you. So now we're going to move through. I'd like to move to the next quickly. The next 4. The reporting piece is obviously going to be critical in this, and so the reporting you can imagine the amount of new reports are going to have to be. I grouped them here and think you can look at those, but you're going to have to do network reporting, physician reporting, hospital reporting, clinical service, and outcome reporting. And you know, if you thought you had to do a lot of reporting in the past, welcome to a whole new round of it, which is going to require data elements and databases that typically are not in one location. So each one of these I could go through it in great detail, which would show you just really how challenging this is going to be. Just if you look at the fourth area, the case management, M&M by service lines, etc., that's going to be a big push. And I know there's a lot of eminent or like domain providers out there that will talk a lot about that, but it's going to really come down to your IT systems and whether or not you can generate that yourself. So these next couple I'm just going to run through. I want to differentiate for you. What I'm talking about today is really value-based care. The level 2, which many of you will be at in the next 2 to 3 years or 4 years, will be actual total risk management capitation. And I'm not going to talk about that today. That's a whole different set of issues. The next slide, just to talk about what would exist in each one of, here's what we're talking about today, combining physicians and hospitals and looking at EBM guidelines, etc. I'm going to write the level 2, the health systems. Then you're going to really get into even more requirements, and I think many of you may are looking at that, maybe you're looking at that. That's going to require yet a second level of performance standards that is a whole different ballgame of you actually becoming a payer yourself, and that's secondary. But let's take a look at what let's end this really with looking at your IT platform for a value-based revenue cycle, and here are the areas that I think you're going to need to make some enhancement to, likely from what you're currently at. The whole patient enrollment and eligibility, contract modeling across a continuum, namely including physicians in the contract modeling environment. That somehow is going to have to be done in the same platform. How are you going to maintain multiple CDMs and fee schedules? Because at some point you're going to have to take a financial connectivity between the physicians and hospitals, and nobody wants to not get paid in that environment, so you're going to have to deal with that. The whole issue of case management and referral services. How is your system going to go outside of the four walls of the hospital to do case management across the continuum? The next area is claim repricing, clearing, and payment. And again, your claim system really needs to be updated to be able to take additional elements into your claims, be able to reprice those claims with value-based criteria, and then clear those claims back to the payer, and then receive the payments and distribute money. You're still going to have dispute resolution in the value-based area, and you're going to have a system that can deal with disputes. And then finally, you're going to have a whole new notion of risk sharing, gain sharing, and treasury services, what I call treasury services. Some environments got to pay all of you that are connected in a value-based system. The platform features you probably need to look at, if there's any IT folks on the call today, you're going to have a lot of operational sort of features that you need to look at. Integration features, you know, how you're going to integrate from these multiple data sources. And then a whole issue on BI tools and analytic features. How will you do that business intelligence to give yourself a chance to perform better and to have the necessary resources to keep your organization going? So here's the integrated care platform, patient enrollment and eligibility, contract modeling. Really, I'm just reinforcing what you would need on a platform to be able to do the work of this. And I'm not going to just go through these and then do a checkpoint and we'll end the discussion. Here's some of the basics you can look at. You're going to have to receive enrollment data from payers. Number 2, you're going to have to communicate that patient roster to the physician offices and hospital registration. You all have to be on the same page on that. You have to monitor the employee benefits and eligibility. Probably more use of EDI transactions and portal interfaces. That's something that will need to be sort of tacked on to your current IT systems. And then the whole transmission of information across the environment. Really, how do you take that enrollment and keep it relevant that's the network management piece of it is part of that as well. But contract modeling, again, value-based contracts, you have to have good historical claims data and good projections. You need to create a master library of these contract terms. We need to communicate the terms to providers for verification. And in this case, I'm talking providers equal physicians. That's typically the language of managed care companies. They call physicians providers and hospitals facilities. I never liked that term facilities, but that's what hospitals are in their mind. Anyway, that's where you have to do reconciliation. And then you need to be able to identify and reconcile payer variances. Those are not going to go away in value-based care. People are going to make mistakes. They're going to look at a contractual term and say that it wasn't fulfilled correctly. And so the whole business of denial management is not going away in this. It's basically or underpayments, et cetera. We're still going to have to work on that. Network management, here's another big skill set that typically is missing in hospitals. They have to create a provider network database. Again, Blue Cross will happily do that for you, but if you don't have it yourself and you aren't maintaining that, in my opinion, the health system needs to be the course of last resort as to who's in and who's out in the network. And there's a big lag time right now, and I think managed care companies don't like the performance of that either. So somebody has to maintain the network, and my proposal is that it really should be the hospital and the payer both independently keeping track of the network. General communication, blah blah blah, on that. As you look at network management as a big issue. The next area is this whole CDM fee schedule. This is the area of the food fight. I mean, this is the difficult area when hospitals and doctors get together to begin talking about if we're going to have bundle agreements or episode agreements or shared savings, etc. What is everybody getting paid? And this can be a very uncomfortable environment for health systems to deal with because physicians have been separate, because hospitals have been separate, because the whole system has built people around the whole notion of separate fees for separate procedures. When you start combining them, you inevitably get into the situation of saying, who gets what of what, and that is a life-changing environment for some people when they have to do that, and it's something that has to be done if you're truly going to have an integrated care system. And then the multiple charge scenarios, you got to really kind of become very granular about it. And then that changes all the time. You have to communicate it, maintain it, modify it, etc. And a health system is going to typically be the one called on to do that. There are more resources there and more administrative infrastructure than trying to have it sitting alone in the physician. Utilization management and referral, everybody does this, but you've never done it in the same context as it's going to be required in the world of value-based payment. And so you see a couple words in here, report triggering, attribution, multidisciplinary teams, work listing, timely notification authorization transaction. That's going to be a big one. That's going to be big in the context of denials and appropriateness. Was this person in or out of the network? Did you notify appropriately, etc.? So a lot of new things in this area that everybody thinks, oh, well, we do utilization management, no big deal. Next area is claim repricing and clearing. This is going to be a big deal, and I think there's lots of conversations need to happen with claims clearinghouses and your legacy systems and your contract systems, etc. And again, you can look at that. This is really where this will become an issue, particularly as you get more and more integrated with your different provider groups. Patient engagement services, again, getting into this whole notion of enrollee mapping and admission triggers and patient inquiries and call centers and interactive portals and patient perception scoring, that last bullet. I'll guarantee you in every healthcare, in every managed care leadership room, this is going to be a major issue of what you get paid. How did the patients perceive your care? If they didn't like it, it's going to cost you money. It's that simple. Performance and dashboard reporting, you think of three different areas: care management, administrative, and financial. And that reporting. So let me just close with kind of a thought process of what I think needs to be done for a health system for a health system working with a payer for that matter is, and I think in the health system side, my opinion at this point, talking to C-suite folks all the time, I think we're in a little bit of a denial in the healthcare industry about whether or not what we need to do is change the revenue cycle environment at the institutions. And I think that we're kidding ourselves if we think that somehow what we have now is going to be there. Let me reiterate my point that I've made earlier. I believe that this isn't about clinical care transformation, it's about revenue cycle transformation. We are moving away from discrete fee-for-service as its only way of being paid to a much more nebulous and interpretive environment of value-based care, and we better do a complete job. So first and foremost, I think every health system with C-suite involvement needs to establish a revenue cycle effort regarding value-based payment across the revenue cycle continuum, and include the physicians. You got to really, don't hide from this. This is something that's real. Then within the RCM department, if I were to, what I would call in a larger system of RCM VP, who would typically have these different departments access to him or her, the managed care services, patient access, patient financial services, case management, financial reporting, and receivables management, to really be brought together as a workflow. And this is what I would look at on a checklist. I would say, okay, managed care, do you have a value-based contract calculation tool? What do you have in tools to be able to interpret and to build contracts? Patient access, do you have the capability for enrollment and authorization? How are you going to be able to handle 30,000 Aetna lives that you just signed an agreement with? How will you know where they are, and how can you get it across the continuum? The third area, the patient financial services, billing rules and claim file information. Well, what's going to happen in that value base? How are you going to do your billing? What's going to happen there? Your customer service group, how are you going to deal with enrollee and patient calls? You really need to know all of the nuances of this value-based care. Care management, evidence-based rules and managing clinical data, but how are you going to be able to manage that, and how are you going to update it, and how will you engage with the medical community in doing that care management? And remember, care management isn't just sitting in the OB department, it's starting in the perinatal office, and it's dealing after the fact if you're doing value-based. Finance people, the net revenue is going to be a big deal. I think net revenue is something that everybody's kind of just thinking, well, we'll get the report back from Blue Cross 6 months from now, we'll see what we did. That's not, in my opinion, the right way to do it. I think it needs to be done more on a timely, real-time basis. And then enterprise reporting, which kind of everybody does, is how do you report for the enterprise when you got physician groups and you may even have some subacute care, some home care, et cetera. How are you going to do that reporting? So that's a big issue to me. Here's my summary. I just want to think of the substantial IT investment each of your institutions in HIE applications that have been spent in the last 5 to 10 years. We're so well into the billions, it's not even close. In fact, I know several hospitals have spent $1 billion alone in EHRs and HIE applications, just getting into the MU side and the clinical integration. And now, at the same time, think about the IT investment in coordinating and transforming the revenue cycle requirements of integrated care and value-based contracting and payment. They're absolutely miniature compared to the clinical integration. And let's think about it. 10 years ago, you had a cardiac system and an ER system and an OB system and a blank, 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 and you merged all of those into a common electronic health record. Many of you took, Epic's been a big winner. Cerner's still out there. Meditech's a big winner. These are the players. And those are the legacy systems. But think of the amount of money that's been spent there. Now think about how little has been spent really in the whole revenue cycle environment, which is all about. And I think it's pretty staggering that we haven't done that. The revenue cycle transformation, and as I said a second ago, the clinical partners are transforming the old ADT systems and physician PM systems into a smarter system. The revenue cycle side of the health system needs to catch up with this clinical integration / value-based care. It's really all the same. And then the revenue cycle leaders need to become partners with the clinical leaders. That's the area that I think has the greatest opportunity here. And that's how I finished the presentation today, and thank you very much. I'm happy to take whatever is left. We only have about 5 minutes left for some questions, but happy to do so. And I guess I need to ask a third question here, and
that's right, Nick. I'll pull up the third question and display it now. So Nick's third question concerns modeling VPP contracts, and the requirements for that is one of the following options: population health data, charge data, physician network information, all of the above or none of the above. So if you can take a couple of seconds now to respond with your feedback, that would be great. And then I'll turn it back over to Nick for any other questions. And if you do have any specific questions you'd like to ask Nick now, feel free to use the chat box in the bottom part of your control panel. And if not, Nick, I'm sure you're willing to take additional questions one-on-one anytime after the session ends today.
That's correct.
Okay. So the responses show 93% of you selected all of the above. And Nick, you want to comment on that?
Yeah, and that obviously is the correct answer, and they could probably put about 9 other things involved in it in modeling, but those are areas that I think. And again, what I tried to do today, and again, there's a lot of data in here, a lot of information, and value-based care is a huge new environment that there's lots of things going on. And I spent half of yesterday in the offices of a senior health plan group that they're struggling with it. The hospital systems are struggling with it. CMS is struggling with it. And there's no quick answer. I hope I didn't come across as saying that there is a simple answer. But the more the smart people like yourselves that are in the financial side of the business get involved in the value-based side of this, the better it's going to be managed in the future. We can't allow simply the senior strategic players to be out negotiating new agreements that the revenue cycle is going to have to handle at the end of the day. I believe very strongly in the revenue cycle environment, and that a well-informed and well-managed revenue cycle can handle any of the new changes coming in, and one that isn't is going to have trouble with it. So again, thank you very much for listening to me, and I'm done if somebody wants to ask a question.
Yeah, and I'm not seeing any questions coming in now. I know we're coming up on top of the hour, but Nick, thanks again. That's an excellent presentation. You did a great job of condensing 8+ hours of content into this hour-long format. But again, for any of the attendees who'd like to follow up with Nick with specific questions or additional detail, I'm sure he and his team will be happy to drill down into the details with you. And his contact information is going to be available in the presentation slides that, once again, are going to be posted on the Tennessee HFMA website. Just click on Education on the home page and select the webinar, and you'll see not only today's presentation slides and content, but also previous presentations and webinars as well. So at this point, again, thanks to all of you for joining us. Appreciate your interest and participation. And Nick, thanks again to you and your team. Thanks a lot.
All right. Bye-bye.